Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. This is Aebhric Kelly. This week, we are again with Alfredo Leal, who is our clinical coordinator for Quorum. Alfredo, welcome back to the program.
Hello, everybody. Thank you, Aebhric. It's a pleasure to be here again.
So, tell us a bit about yourself and what's keeping you busy.
A lot of stuff. So, I'm still a firefighter, a fire officer in Portugal. I joined the fire service in 95, and I started also as EMT, and then became a paramedic. I did my paramedic course, just 1 year course in Denmark, and then moved to UK. When I started working with the NHS, National Health Service in the United Kingdom as a paramedic. And then I decided I want to do something else. After 10 years on and off working with the ambulance, I decided I want to do initially offshore, spent some time in vessels and oil rigs, like the one I'm currently on. I'm offshore of, I'll say, the Mediterranean Sea. So we're doing some work here, and the weather is actually quite good in comparison to the North Sea. And did some work in Afghanistan, in the work in Palestine / Israel, also in Gaza and the West Bank with the WHO, and also in Ukraine, in a place called Severodonetsk, when the times are not that rough as they are right now. Currently, I'm working offshore, doing some ambulance work in Portugal and also in the United Kingdom, and as you said, working with Quorum as a clinical placement coordinator. And I think it's me in a nutshell.
So, Alfredo, you got a job with the World Health Organization as a paramedic. How did that work? How did you get that?
It was not specific as a paramedic. The title was a pre-hospital consultant. So I was hired to go to Palestine. It's divided into three per se: West Bank, Gaza, a strip, and there's another part that it doesn't count as Golden Heights. But again, these two, mainly the West Bank and also Gaza Strip. I was asked to go there for 3 months and assess the ambulance service over there, mainly the Palestinian Red Crescent Society and Ministry of Health and other organizations were working over there. Of course, was before the war starts 7th of October. So it was before that. It was some tensions going on, but not as right now. So if I'm going back, everything that I assess, it could be completely different.
Still a great experience.
It was.
And you've been in the east of Ukraine. What would you be comfortable discussing about that deployment?
So I was hired to go to Ukraine with a company called Icarus to work to give support to OSCE. It's an organization that is similar to the United Nations, but different. They got a different mandate. The idea was to be there to monitor the peace agreement called the Minsk Agreement at the time that was having its faults. It was every day we had some conflicts going on, and we're there to monitor it. And I was there to cover the monitors, pretty much all over Europe and other parts of the world. We were there monitoring the conflict. And if something happened, I'll be there to give care under fire eventually. Throughout this mission, before I left, the only person that actually died on duty was actually a paramedic, which is kind of strange. But it was easy job per se until it isn't. So if we get caught in a firefight, couldn't be much great per se. But again, it's part of the job.
I imagine those jobs will be back again once Ukraine gets their country back. They're going to have to be monitors on their border.
I presume so. Hopefully, it'll happen as soon as possible. Not talking about myself, but for the people of Ukraine and also people of Russia. I know it's a conflict. People tend to take sides, but for what it worth, war is always bad and always give casualty and suffering. And in suffering, ideally, we want to get this over as soon as possible.
Not soon enough. So, Alfredo, you and I, a fortnight ago, went to Ireland to take the Advanced Medical Life Support course, the AMLS, and we had to do this in order for you and me to become AMLS instructors next month during our official NAEMT site visit for the college. And I brought you on to the podcast today because you have years and years of experience teaching NAEMT, and now that Quorum is becoming a training center, I wanted to pick your brains, but how was your deployment to my country?
Yeah, it was great. I've been to the Republic of Ireland many times. It's a great place, and we had the chance to do the advanced medical life support. For me, it's the third time as a provider. I think my first time that I did it was the year 2010. It was back in Portugal. Although the course is older than that, so I think the course originally was conceived in the year 2000. And this course kind of changed who I am as a healthcare professional, because it changed me actually, because it gave me some tools and it changed the way I think every time I look at the patient. It's like the Dunning-Kruger effect, this interesting graphic that goes up and down. So at the beginning, I think I know everything, right? After finish the course or after finish paramedic course or degree, so your confidence is quite high. But then you realize that you don't know much yet, and if in the same time you start becoming complacent. And why? Because the job that you go, most of them are medical, and it's not trauma, so it's not sexy. And that word "sexy" is not mine; actually, it comes from the AMLS. So we go to loads of non-emergency calls, and most of the times the way we approach another call, someone that actually doesn't need an ambulance. However, we normally don't think about what was the reason for the person to call us. So they need some support, they need some help, and we sometimes think, okay, patient is not life-threatening, why am I here? But I think medical emergency is a lot more than that. At the time, in 2010, I was a technician working in Portugal, and I was always told, okay, it's not your job to think, it's just to transport the patient from A to B and no questions asked. If you want to think, you need to become a doctor. That was the mindset, and actually, it still is a little bit nowadays. With the MLS course, I learned that we technicians, now paramedics, learn by pattern recognition, by experience. So we see a shortness of breath, and then you see the patient posture, that patient assessment triangle coming out with the pediatric assessment triangle. You look at the patient, see something wrong. And then years later, you're going to go to another shortness of breath, and straight away, you're going to recognize that pattern and you know what's going on. However, you need to recognize and confirm what your gut feeling is telling you. And the MLS gave me the tools to process and organize all these thoughts in the right way for the best of the patient. It's not for myself, because myself as a clinician, I'm not important. Important is the patient. And if I can give the best possible assessment and treatment to the patient, the better.
That's true. And I was just thinking back as you were saying that on my career since the late 80s and how much focus there is in trauma. So my first trauma course was in the late 80s with the Sheriff's Academy, and we didn't even have a name. There was no PHTLS or ITLS or anything. It's just, blood, red stuff's coming out, push on the red stuff. There's no talk of blood or tourniquets or anything like that. It's all been trauma. And in the Army, it was all trauma. And then as a paramedic, and now a critical care paramedic, it's trauma. I've taught more trauma than I have medical, and it's always been the focus. And you said the word sexy. It's just
Yeah.
fun, right? It's easy.
Yeah.
It's CABC, push where the red stuff is, give more red stuff. All right, we're good. And there are few courses out there that focus on medical. And of course, Coram had to design a bunch like the eye care and things like that because there was a deficiency. But AMLS focuses on this. And you took this, 15 years ago, 16 years ago. So what is it about AMLS that made you a better medic?
So it's to really assess the patients and how to play with sample. For instance, now we call sampler the last R, risks associated, and with Coram way, recent travels. This is also important. But again, imagine if someone is taking beta blockers, right? We know that probably that person is not going to have a tachycardia if he goes into shock. Septic shock, for instance, and you know that the beta blocker is going to prevent the patient goes into tachycardia. If he, that information gives you this false sense of comfort, means that the patient is stable, and you don't understand what's going on with the MAP, arterial pressure. You don't give much importance to the entitled CO2, even the pulse pressure. If it's less than 30, you don't. Normally, those inputs that the monitor tells you that it looks all right, but it isn't. And then all of a sudden the patient crashes and you don't know why. So I think MLS put everything together, all together, and made you think, okay, things can go wrong due to X, Y, and Z. So playing with medication and past medical history, I think was the take home stuff, the most important thing for me to become a medic and to work probably asthmatic. Medication and past medical history. Another one, patient got asthma and taking a non-selective beta blocker for headaches. And if you've got an asthma attack, salbutamol won't work because the patient is taking propranolol. So those tiny things that made all the difference, because then you need to change your strategy how to treat the patient. And then there's something else at the ends of the course called differential diagnosis or field diagnosis. We need to come up with three probable causes. Again, with the college, this is something that we commonly do during our courses. Okay, what's the differential diagnosis? However, in countries that I used to work, if you use the words diagnose, this is considered a blasphemy by if you're not a doctor. So you need to be very careful the words that you use, or else they start looking at you and who are you to saying the word diagnose? Are you a doctor? So no, I'm a paramedic, and this is what I have. This is what I think it is. I cannot fully say this is definitely diagnosed because I don't have all the tools on the roads, but this is my rationale to treat the patient as it is and to take the patient to this specific hospital and not the other one across the street.
That's a good point. That we push heavily on 5 differential diagnosis, and we teach this to students. And I haven't spent a lot of time thinking about what are our graduates going to do in a country where they're not allowed to say the word diagnosis. And it's just a word, isn't it? So we could just say, what are the 5 possible ailments that your man's going to have?
Yeah, but it's a question of wording, of course. But you're treating a patient with a fracture, an open fracture, different from a patient having a heart attack from the patient having a stroke. So you have to do some sort of diagnose or suspicious of to give the patient the right treatment. I understand 20, 30 years ago, there was a specific profession that's got the rights and is protected to just to do diagnose, and the paramedics and nurses cannot use that word. At least in Portugal is how it is still today. But actually, pre-hospitally, you need to make a decision in order to give the best treatment possible for the patient. If the patient have a patient with a heart attack, you're going to take him to a hospital with a cath lab. You're not going to take to the GP surgery across the street. For the opposite is to have a broken fracture or the other way around, a chest infection, probably could be dealt with the doctor surgery with the general practitioner. So we are doing diagnosis regardless, but sometimes the wording is
yeah, each country has their way of doing things. In the UK, you can't call yourself paramedic unless you're ACPC. I completely agree with that. So for this AMLS, and mainly because we have an assessor coming to grade us to make sure that we're up to NAEP standards, I spent a ton of time learning the AMLS patient assessment. Did you and we didn't hardly use it at all during the course. Do you find that useful, or is that something that you just look through like, yes, I cover that in my own assessment and I'm going to do it my own way?
What AMLS in most of the courses are telling us, they're showing us a structured way to do our assessment. But in reality, this is not how it works. So sometimes you go to a job, you arrive at the door, you've got a relative bombard you with information about the patient's past medical history, and the patient is the other side of the house. So you're not yet seen the patient, you're already doing sample. Approaching the house, the patient, bear in mind, you're not seeing the patient yet. On the left-hand side, you see an oxygen cylinder. In your mind, you're just saying, probably the patient's got COPD. And again, you're not yet seeing the patient, and you're doing sample, and there's scene safety. So everything is dynamic. So the MLS schematics, right, the approach to the patient, like the PHTLS, they're nice tools for us to not forget some elements. So at the end, right, before we leave the scene, everything needs to be fulfilled. But the way we gather information has to be dynamic, because we're going to be bombarded with information, and there's some information that is not right, and sometimes the relatives give us the wrong or less correct information. I'm not saying they're prone to lie, but there's sometimes information gives us not correct, and we need to, I'll say, dance with all the information to make sure that we get the correct information to give the appropriate treatment. That's the beauty of AMS.
That's a valid point. Like PHTLS is linear. Well, to be fair, we do jump around from CABC back to A, but it's linear. CABC,
Yes.
DF. Well, and we do G and H, but we won't get into that. Well, AMLS and all medical, you just jump around a bit, and it's harder So when I was looking at that AMLS assessment, there's 5 categories. There's a lot of jumping around, and it's not as easy to remember all the aspects. Where I'm finding the quorum chart mnemonic, or in the U.S. Army we called it SOAP, and I expanded that SOAP and created chart because I'm a knuckle dragger, and it's easy for me to remember that. For our medical, that we do get everything within the AMLS system eventually, but trauma is just you just follow your CABCs.
Absolutely. Trauma it's kind of easy because you're going to do CABC or XABC and then DE and follow the college, the rest of the alphabet up to Hitman, and then beyond Hitman. So there's a lot of is a mnemonic, is a schematic. And as you rightly said, sometimes we need to jump around. If the patient it's in shock, right? But the airway is not clear, we need to secure the airway first. But sometimes the airway, now the patient is breathing, is not great. We come up down to C, and then they need to go back to A to fix and then put an advanced airway. Because at the moment, the NPA is there, but the patient is vomiting, and vomiting blood, and there needs to be suction again. So it's dynamic, such as MLS. You need to get the information that you can, and sometimes the patient on purpose don't tell the information because they want to give this specific information that is more quite sensitive in front of the relatives. But in the ambulance on the way to the hospital, if you ask again, you're going to have a completely different answer.
And speaking of the CABC, quorum, we adopted the CABC, and I taught that on battles with the British military, and I just kind of brought that on board. It makes sense. The NAMT uses XABCDE for the AMLS and PHTLS. What are your thoughts? Because you've used both, haven't you? So is there any benefit on either one?
Sorry, say again, CABC and XABC.
Yeah.
Right. Actually, that's an interesting story because you go back to got PHTLS that is getting information from ATLS. It was created a long time ago, right? It was Dr. Norman McSwain that creates a PHTLS in 84, I think. And then all the information that we have nowadays with PHTLS came from ATLS. However, there's some competitors, and was one time that a competitor came up with the C for catastrophic bleeding, and it was adopted. And then I think it was the 9th edition, 8th or 9th edition, PHTLS brought the X for exsanguination because they need to put something else and it cannot be catastrophic bleeding at the same time. So the rationale is there. However, if you go and do PHTLS in the United Kingdom, the British version, they're going to use CABC. But you're going to buy the American version, you're going to see XABC. So it's exactly the same. Even the course is the same, just that the word is different.
One other thing I noticed on our AMLS is there wasn't a lot of discussion on MAP, and it was just systolic. And it's for a medical course. So in eye care, we teach MAP pretty strictly. MAP and urine output. Those are the things that you really need to keep an eye on. And there was little discussion on either in the AMLS.
True. AMLS, MAP, millimeter mercury pressure. With PHTLS, we always think about patient going to hypovolemic shock, and we've got a minimal of 65 to make sure that the brain is perfused. Minimum 65 of millimeter pressure. MLS, we're dealing with medical patients. This is also important, but because we can have hypovolemic shock in medical patients, like diarrhea and vomiting. We talk about cholera and malaria, and then the patient become dehydrated. It's even burns, but again, burns going towards trauma. But the MAP, it's important. I think we need to consider about what is about pressure. The blood pressure means to perfuse the noble organs, mainly the brain and heart, and you need to have a mean of 65. If it goes below that, you're going to have problems. Something that MLS brought as well, and PHTLS also covers, is the pulse pressure, the systolic minus the diastolic. And if the systolic diastolic become too close, it means that the heart is not pumping as it should. So it means that the flow is not going, and the risk of the patient goes downhill and goes into cardiac arrest is also real. So those are things that we need to monitor to see if the patient actually is improving or deteriorating.
Alfredo, you've been an NAMT instructor for a very long time. What courses have you taught?
Right. PHTLS was my my main course. Again, my first PHTLS as a provider was 2005, then became an instructor afterwards and run courses in Portugal and UK, and now I'm going to run my first in Malta. There's other courses, AMLS. I never actually run AMLS. I ran one of the similar, but now I'm glad I'm going to finally become an instructor of MLS after my third or fourth third provider course. There's other courses that AMT also teach. One is quite dear to me. It's called All Other Disaster Response, ARDS, AHDR. That's the one. All Other Disaster Response, and it covers mass casual incidents. As you know, I focus in the last 2011 onwards in mainly on triage. Of course, this course got dear to me because it shows how we're supposed to manage mass casual incidents and what type of incident it is. And actually, you can extrapolate from a house fire to even to have a problem, cholera problem in the middle of a village in a country a little bit far away. So we need to have multiple casualties. So we need to, or casualties or injuries or ill patients. We need to classify them, come up with a destination for them, what to actually need, what kind of hospital they need, and how can we manage the scene, especially with not many resources. Sometimes we think, and especially in UK, it's common to think about that. I'm getting deployed to a site, and I know eventually I'll have 20 ambulances in the next half an hour. But if you work on an island, for instance, you only have 2-3 ambulances. If you have 15 patients, that's it. You need to find a way to classify them using the triage system that is implemented. It will be a 10-second triage or a SALT or any others, and transport the patient, prioritize the patient, the patient in terms of condition, and also if they're able to survive the trip. Because if you allocate an ambulance to take a patient is going to die, you know that the patient is expected, and is going to take this patient and ask a half an hour drive on an ambulance. What's going to happen? Probably the patient is going to die on the way, and you lost an ambulance, and now we don't know when the ambulance is going to come back, and you still have about 10 patients on scene to go to hospital, get the treatment they need. This is one course. Another one is also dear to me is the emergency pediatric course, the EPC. Is similar to a course, and I will say competitor, but they work hand by hand, called Pediatric Education for Pre-Hospital Professionals. And I'm saying that because sometimes the EPC use the PEP manual. They use the same language per se. It's how to assess the patient, the pediatric patient, something that I already mentioned, the pediatric assessment triangle. Look at appearance, work of breathing, circulation to the skin, and in seconds, even without talking to the mother to see what's going on or get information whatsoever, just looking at the child can confidently say if the child is critical or not critical, and from that moment on, act upon what you're saying. So those two courses, there are others such as MS Safety is also a good course that they give you some tools to prevent accidents from happening, especially in the pre-hospital environment, the ambulance work, ergonomics and seat belts and driving assessment, the conditions of the ambulance, and many other things that we need to take into consideration. But these two, AHDR and EPC, are, as I mentioned, dear to me.
So you're already an instructor for those, so we'll be able to get those pretty easily. Is that right?
Yes, I am.
I'm also looking at the geriatric, the GEMS course that might be beneficial, but we're starting with PHTLS and AMLS, the two big hitters. And as I was discussing things within AMT, I was looking around Europe. There's not a lot of people that offer AMLS. Oh, here in Germany, I live in Germany, there's tons, but it's all in German, unfortunately. But every other country, there's very few, and very few in English. So I'm hoping that maybe we can create a center of excellence of AMLS there in Malta.
I hope so. Funny you mention, I came across, I'm always looking for how the industry is in terms of jobs, and a job offer passed again in my list for an offshore nurse in Norway. I'm not a nurse, I'm a paramedic, so I will never apply to that job. But again, for similar role as I am as an offshore medic, they were asking for that specific role, the AMLS course. So it's something that it comes up depending on the role. But for offshore nurses in Norway, at least that particular contract, the client was asking for MLS. So it's something that could be an option in the future, and that will be again, some offshore nurses may be interested to do the MLS.
I think it's going to be a good benefit for our paramedic students, year one degree paramedic students, to get PHTLS and AMLS. Currently, they're getting ITLS, and we are now looking at offering PHTLS. So we'll see if Dr. Tom Mallinson will accept PHTLS and AMLS into his paramedic students.
Perfect. Looking forward to it. Looking forward to run the courses in Malta next month.
So, Alfredo, you've been with NAMT for ages. Tell me, what do you like about them? What do they do well?
NAMT, the National Association of Emergency Medical Technicians, they were created to got paramedics together and start producing knowledge. I know paramedics don't tend to dedicate much time on research, and there are always some courses that start feeding NAMT with knowledge for them to adapt to the pre-hospital world. So PHTLS is an example. You've got the advanced trauma life support that feed all the information to PHTLS to pass towards the pre-hospital environment. TCCC is the military version. We also have not just ATLS, but other parts, especially the experience in the most recent wars, are feeding the course, because it's not just for the pre-hospital professional paramedics per se, but for the tactical medics, the soldiers that go out and need to deal with wounded soldiers. And then we have the TECC, it's the version, civilian version of TCCC for, imagine, for police, or if you have a tactical operation, police tactical operation, active shooter. So we've got a few people who got shot, and now we need to have their paramedics or EMTs, police EMTs, to intervene. So we receive all that knowledge and apply and train the right staff to provide the right care. Is mainly that, because if you think about the timeline, right, it's got several branches. So for medical is AMLS, for pediatrics will be EPC, and many others. So it kind of it does what I used to call emergency 360 degrees. So it covers pretty much most of the patients that we attend in the pre-hospital setting, including some of us that go go abroad to attend wars and other places. It will also give us those skills, for example, CCC, to deliver the right care where we are. So it will be the civilian or a battlefield or whatever.
Let me throw you a wee bit of a curveball. So you are now CEO of NAEMT for a day. You have God status within NAMT. What program would you add to their portfolio?
Mean question. There's a few. I just mentioned the emergency 360 degrees is an exercise I tend to do to cover the patient the moment they were born until they die. So we almost covered the moment they die with GEMS, geriatric for AMS. I think there's a few areas that already exist with American Heart Association that NAMT never want to go in, but they'll link. So the newborn life support, advanced life support, and pediatric life support. Again, pediatric life support is briefly covered with the EPC, so it's not neglected. But the resuscitation part, I think that's something that AMT could consider. There's some other parts, of course, is quite dear to us, is the wilderness and remote applications. That the remote area is something that NAMT, not as far as I'm aware, not yet approach, but I don't know, who knows in the future.
Yeah, they've kind of steered clear of the whole ACLS option, even though on the NAMT website, they do have the ECSI ACLS option. So they've kind of steered near it, but they haven't embraced that at all.
I don't know how it is at the moment. There's a few organizations that were running advanced cardiac life support and also pediatric advanced life support, but they're kind of slowly moving away. The other one is HSI, another organization that used to run it. I think they're still running ACLS, but they're moving away. And I think American Heart Association are the ones who actually have that niche in terms of delivering training and knowledge. Again, every 5 years, the guidelines change. We need to adapt ourselves, especially with ILCOR. If you're European, you need to follow the European guidelines, the European Research Council. If you're American or dealing with American guidelines, will be the American Art Association. And there are 5 other organizations worldwide that also create their own guidelines in conjunction, in synchrony with ILCOR. So it's a niche, but again, it all depends if an AMT wants to go down that route or not. So it's political. So you mentioned about CEO, that's all I'll do. But as I said, it's a mean question because it's many information I'm not aware, and a CEO needs to see everything.
Yeah, that is a challenge. And you're right. It's interesting that they haven't touched the wilderness and remote at all.
Yep. Be option. Who knows? Rome is expert in that area. So who knows? Eventually, a partnership with an AMT could produce a course for AMT to run worldwide. A challenge, huh?
And in all fairness, IBSC has cornered that market with their wilderness paramedic board certification, which a lot of us at Quorum has helped write that and help create that. But that's the only thing at the moment.
Correct. Dr. Mollison produced that manual, and actually it was very good. I managed to certify it as wellness paramedic with IBSC, and thanks to that manual. So it means that Quorum is producing knowledge.
Alfredo, my final question for you is this. What advice do you have for the new medic, the new nurse, the new doctor who is just starting out in their career in austere medicine?
It is to adapt and to learn as much as you can before going to the field, and prepare yourself before going to the field. Because depending where you're going, if it's Amazon or the Arctic Circle or the deserts, you need to understand what's going to be your challenges, what kind of disease or trauma, or what kind of the epidemiology that you're going to find over there. So it means that you need to come up with a pack of medication that's going to be appropriate over there, and your own kit. So it's pointless to bring loads of clothing to the desert, but you need to bring appropriate clothing to the desert. The same thing works for the Arctic Circle. So you need to adapt yourself to protect yourself and try to understand what you're going to find over there, who you're going to cover, to prepare, because I think the key word in a wilderness environment is preparedness. If you're not prepared, you're going to fail. And if you're going to fail, you're not just fail yourself, you're going to fail the ones who are counting on you. And also, there's another detail about you need to prepare yourself mentally for what you're going to find. Sometimes third world countries, you're going to find a different culture. You're going to see things that you're not expecting to see, and you need to prepare yourself to cope with that information and those scenarios to not regret afterwards. I think it's what I think. This is my advice.
That's good advice. Fredo, it's great to have you back on our podcast. I'm sure you'll be back for your third time eventually. I also, personally, I would like to appreciate the push you've had for an AMT program. So you went out of your way, you got your AMLS along with me in Ireland a fortnight ago, and you are coming to visit, so you're there to support us. And as clinical manager, you are making our students have a better option as they go through the program. So Alfredo, everything you touch within the college has been golden, and I appreciate your time.
Always a pleasure. Thank you for having me.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.